Prostate cancer is going to affect 1 in 15 of us at times in our life from 40 on, and testicular cancer from 15 to 40. Testicular cancer, as we'll see, is the success story for men's cancer and for solid cancer. Testicular cancer, if you find it early, you can save tons of treatment, but if you come in like Lance Armstrong with the worst testicular cancer, you can cure it in the majority of men. And so it's a success story of radiation chemotherapy. But again, what we're going to focus on is prevention and such, and hopefully not get to the point of needing all those. So we're going to do a primer to survival, prevention, survival, and empowerment, meaning if we take charge of what we need to do, we will be successful. So what are we going to do, completeness? We are going to talk about, hey, can you prevent prostate and testicular cancer? You're going to say, what do you have to do an early diagnosis? Because I think you've heard that for any cancer, whether it's a skin cancer, whether it's a breast cancer, whether it's a lung cancer, if you find it early, the vast majority are curable, and the most important thing is less to do to cure it. What is survivorship? Well, you've had awesome survivorship talks. There's a couple nuances we found with men that I'll share with you, but I think it'll complement what Dr. O'Brien told us. So financial disclosures, I'm supposed to tell you that I get no money, but the Vermont Cancer Center gets money in my name from these people doing research. So prostate, what the heck is the prostate? The prostate gland is a 30-gram small gland that sits in the area where the bladder empties through the urethra, and it has one job, and that job is to make the fluid that comes out when a man ejaculates to make the sperm happy. That is its job, and this little 30-gram walnut-sized gland makes all that fluid. 10% of the fluid comes with the sperm from the testicles, and a little bit of fructose or sugar gives the sperm energy from the seminal vesicles. So the prostate gland is definitely just for reproduction, but a funny thing happens. I don't know if we were designed not to live past age 30, but from age 30 on, this little gland continues to get bigger and bigger and bigger. And almost every man age 50 will have some bladder irritability. It'll be slow to urinate. They might get up 10 times a night. And 1 in 6 of us will need a treatment for non-cancer just because it gets so big. And the good news with that is 80% of men you could fix with a prescription herbal or a medication as opposed to surgery. But the other side of the coin with prostate is, of course, prostate cancer. But here's a couple real-life pictures. The prostate gland, if you were looking in a man's urethra, trying to get into the bladder, this is the prostate. It actually goes right around the urethra, just by where it lives, so all its little ducts can get in. But when you're in the bladder, one of the things it does, it can get big in lumps and bumps. So this is what causes the urination problem. This is not cancer. This will never be cancer, but this affects a number of men also. This is a prostate cut in half. The urine goes through the urethra, and you can see the difference. See these lumps and bumps? That's the natural enlargement we all have, whether you're 30, 40, 50, 90, and if it gets big enough and closes the water off enough, the bladder gets unhappy enough, we see men in the office, the family doc sees men in the office about urination issues. This area, this horseshoe area, is the true glands, and most of the cancers, for one reason or another, are in here. So again, 2 separate things, natural enlargement, prostate cancer. And one of the rectum lives right here, like when they're doing colonoscopy. You can also feel this part of the prostate. And that's why in some men, a simple physical exam will feel a lump or bump there. That's why for prostate cancer, physical exam is still important. The devil's in the details. This is a photomicrograph or blown up of those cells. And the most important person with prostate cancer is the pathologist for a couple of reasons. One is, do I have cancer or not? And the other one, as we'll see, is what type of cancer. Because the trick with prostate cancer is, number one, I may have it. Number two, 1/3 of the prostate cancers are the ones that could affect my life. So it's almost two decisions. One is, do I look for prostate cancer? And then, okay, I find it, but that's not the end of the world by any means. But what type is it is the next step of the coin. So prostate cancer, 2003, I always use this because this is not a good year for prostate. Prostate cancer, as you've seen, the same number of men get prostate cancer as breast cancer. Not many people realize that. You talk about survivorship, the number of people who prostate cancer will affect their life. This is when it was a tie, and it's gone up since then. So this is not a good year. This is a good year. For good, bad, or indifferent, when a simple blood test, prostatic specific antigen, so this protein floats around in our blood, it's called PSA, it's made by good prostate, it's made by bad prostate cancer. And it came out in about the early 80s in the rest of the world. It was the late 1970s in Roswell Park in Buffalo that they started using it. And because of finding all these cancers, a lot of the bad cancers were found, and the number of men dying of prostate cancer, which because we're all getting older in the US, these lines were going up. So it would make sense if there's more of us in our over 50, you're going to have more cancer. But for once, the number of cancers went down, and it went down in a big way. This is the Vermont Department of Health is great for all its initiatives on education, cancer prevention, but also super great on statistics. And these are our own numbers which mirror that. It shows that the most common cancer in Vermont for men is prostate. It shows that a substantial number of men, it is a factor in their life. What's kind of important is how we do as far as finding early prostate cancer. And the green and the red, we don't want to be. Once it's regional or spread, you can control it, you can't cure it. So 80% of our cancers are in a very curable phase when we're finding them. We get a lot of great statistics, but just 2 points on this slide. One is we do find more late prostate cancer than the rest of the United States. That's a problem. And the problem is simply that if you find it early, 100% of the men are going to be here 5 years from now. If you don't, then you're not going to have that good success. So what causes prostate cancer? Well, as you saw in colon cancer and other cancers, age. As we get older, some of our body's natural defenses fall down, and it's easier to make a tumor. Family history and genetics, this is very important for prostate, because if I know I'm at risk, and then I'm going to be a little more diligent making sure I don't have a problem, and there's some specifics for that. The funny thing about area geographic differences, it's always been a little confusing, because men in northern New Jersey, where I grew up, had more prostate cancer. And if you grew up in Japan, you did not have that much prostate cancer. Some of the area geographic differences are diet, because high fatty diets that we ate in North Jersey messed up our estrogens, give you more prostate cancer. If you ate a pure Japanese diet, it would be just what, Chef Curtis recommended, and they had very little prostate cancer. If you take that Japanese man, move him over here at age 30, by the time he's 60, he has the same risk I have growing up in North Jersey. So diet's important. So our fudge factor is area geographic differences. But it's probably diet and other factors, more importantly. So here's a really big take-home message with prostate cancer, which I didn't even know when I came to Vermont. I came to Vermont 8 years ago next month, and two women come in, a daughter and a wife with a man, and he's 58, and he said, I forget where he moved in from, but he goes, I got tested, I have BRCA, and my doctor examined me, and I have a prostate lump, and I want a biopsy because I have prostate cancer. And I said, what's BRCA? So BRCA is a genetic change, and we all think of Angelina Jolie because it's a boy and girl gene that's not good. It's a gene that if a woman has it, they have an inordinate increase in ovarian and breast cancer, and in boys, prostate cancer. And it is very significant because So the history, we ask the guys now, and they look at you like, why are you asking about my wife, mother, all these people? Is because we want to know if their first-degree relatives have had ovarian or breast cancer. And if it's like, yeah, everybody did, then they get genetic counseling, which is huge, valuable wherever you are, and they have a great program here. If I think I have a genetic risk, they do all the questions and answers and say, yeah, it's worth testing. And if I'm tested and I have either of these types, then I have a 50 to 80% chance of getting a prostate cancer, and if I do, it's significant at an early age. So knowing genetic risk, which is more obvious. Hereditary prostate cancer is my uncle, my dad, my grandfather had prostate cancer. It's almost a done deal. BRCA, you have to know the lady side. And then the bottom line is if I have a first-degree relative, I'm at a little risk. So the important thing is to know, because now as high as 20% of men could know they're at risk and can say, okay, I'm going to keep after this. Just like with the colon, if you know you're at risk, you can keep after it. So what can you do to lessen the lifetime risk of prostate cancer? Well, one is know your risk. Just to know it's out there. Number two is to know the genetic risk. That's kind of where that is. Prevention, we're going to talk about, and early detection is the big bugaboo, and there was a big congressional hearing last Wednesday just on that topic, which I will let you know how that went. So first of all, you've seen this today, and it's so straightforward. Improved diet, exercise with as little as 45 minutes, 5 to 7 days a week, fast walking, you're going to do better. Can you truly prevent prostate cancer? Well, here's a good news, bad news. Over the years, selenium and vitamin E was thought to maybe be protective for prostate cancer because they did studies in Finland with vitamin E for lung cancer and selenium with Dr. Clark did for skin cancer, and incidentally they said, oh, those guys have less prostate cancer. So this was a success story because it was the first study for men that was huge looking at this. And just to show you how, so they had vitamin E, selenium, both none. And to do this and to see if there was a difference, you had to recruit over 38,000 men. So this study was a success story because it was done very well, cost $80 million from the National Cancer Institute, and unfortunately showed no improvement. So that's a success story for doing it, bad news for us guys. So is moderate vitamin E and selenium okay? Sure, but we can't say it's going to help the general population. Another interesting thing that was successful, I told you about shrinking the prostate and how successful that is for keeping men away from the urologist as we get older. Well, the two of the main medicines, which are the same family, this is what shrinks prostates, finasteride, dutasteride. Incredible high safety index. Guess what? It prevents a huge amount of prostate cancers. Now, it prevents the not so bad ones that might not affect your life, but it also shows you that normal enlargement, a tumor is not going to hurt you. There are mild prostates that are related to that. But what's interesting for us in research is a lot of these are using these medications as a model. So when you hear about in the news that those things decrease prostate cancer, they do. Unfortunately, it doesn't affect the ones we really want to find in guys, but it takes them out of circulation. So here's the crux of it. So I'm 59, suppose my sister does have BRCA gene, I have BRCA gene, or even if I don't have any of those risk factors and I want to prevent prostate cancer. Well, one of the things I'm going to say, and you see, and we'll talk about one U.S. Governing board who says not to look for prostate cancer using a isolated PSA prostate blood test, which on the surface is fine, but the problem is we don't want to screen. We don't want to look for every prostate cancer in the universe. We want to find early detection of significant prostate cancer. Now, can we do that? Well, how do you find it? So prostate cancer today in 2015, if you want to find it, you still have to rely on a physical exam where your family doctor or someone checks the lower rectum with a gloved finger to see if there's any lumps and bumps, and 15% of significant cancers you will feel, or you use this PSA prostate blood test. Now what's different is we have way more than that PSA blood test. So what's changed nowadays is If I go in, talk to my family doc, he talks to me about the risk benefits, he'll do a physical exam, I will get a PSA blood test. If my PSA blood test is abnormal, the first thing is it's repeated. Is it real? What's it doing? If it's not terrible, he might say, Scott, we're going to get it in 6 months, see what the trend is. And if it's abnormal again, we now have 2 tests, and these are game breakers. Prostate Health Index is a blood test, Fort Killickren test is a blood test, and they both do the same thing. They look at some additional blood tests from the prostate, and they do all these fancy calculations. And when you're done with all this, where we might have biopsied everybody with one funny PSA, if you do all this, then 60% of the people do not need a biopsy. And that's the big difference. You can do it much smarter, much more selective, and what you read about in the newspaper is totally related to just doing a random blood test. So what is said in the newspaper is correct, but the overall picture is like, we still want to find the guys who have prostate cancer to protect their life. And so if you do this regimen, which is right here, you can do that. Now here's the big, you got to play a little politics, and as Dr. O'Brien said, you got to get active on every level. The U.S. Preventive Task Force, I got to tell you what that is. So that's a group of 15 individuals, some physicians, some statisticians. It is a very intelligent group, and they are appointed by Congress. There are no oncologists, there are no urologists on the group, but they had a big task. They said, hey, when we're looking at prevention, what tests are worthwhile? What processes actually are not safe for people? And what they did, they looked at the literature that is available on doing a PSA and a physical exam to find prostate cancer. And what they found is you had to, first of all, if you biopsied everybody with a funny PSA, you biopsied way too many people, and they correctly said, well, that's dangerous and it causes people problems. So they're correct. What they don't address is the fact that, other testing, other schemes of testing, nor was it their job, because their job is that and cost containment. So there was actually a meeting Wednesday where they really had, I heard a nice knockdown drag out and saying, that's great, you did the right statistics, now we want to address the problem, how are you going to address it? And they did do it with mammography, because originally mammography was not rated as a very valuable test, and they re-looked at it and said, okay, we need a scheme. So you're going to see nice changes with this. So in contrast to this, while this is being decided for this one board of recommendation, everybody else in the world, including American Society of Clinical Oncology, said, okay, if we tackle the problem, what do we do? And this currently is the current recommendations, whether you're in Europe, Canada, the National Comprehensive Cancer Center. And basically what it says is, if Scott is in good health and a 10-year life expectancy, and he knows that there's a risk of having sampling that might only, by the time we recommend a biopsy to someone, there's a 6 in 10 chance they'll have a cancer, if they accept those statistics. And then if I do have a cancer, only a third of those could affect my life and would be the ones to be recommended treatment. If they would accept those rules, then yes, offer an every 1 or 2 year PSA physical exam. So it's pretty straightforward, but you have to know the ground rules. Same way if you were to have a mammogram, know what percentage of the biopsies would be negative, etc. So that's where it is, and the rest of the world is moving ahead. The U.S. Preventive Task Force is probably going to come out with some modifications. What they said was very accurate for what they said, but the trick is, how do we address it going forward? And that's what it looks like right now. What happens if you do get to that point and someone looks at you and says, hey, you need a biopsy. What's a biopsy? Well, a biopsy is just like a finger in the rectum exam. It's done with an ultrasound. This is a needle, this is an ultrasound, and you basically use the ultrasound as a map. So you do a series of biopsies throughout the whole prostate, and then that result goes to the pathologist, because again, the pathologist is the person who is the most important person for prostate cancer, because their cells could look good, they could look suspicious, they could look bad, and I can't tell the difference, but this is not cancer, this is cancer. So you need the pathologist, and they are a wonderful group. Pathology is changing hugely. Originally, we had this 2 to 10 score looking at the cells. It gave us information, but didn't really tell us what's a bad cancer. Now, was actually saw it in the Wall Street Journal last week. There's a new prostate cancer typing where they basically have 5 types. And the first 2 types will not affect your life for 20 years, so you can actively watch it very safely. The others could potentially. And now we have looking at the genetics or the genes of prostate, and you could actually look at the different cells. Some aren't so bad, some are good. So pathology, so you'd have a biopsy, pathology, and then you'd decide. There's a lot of other good information for us guys if we have cancer. Finally, large groups of patients and cancer groups are getting together, and if I did have a prostate cancer and I'm deciding what to do with it, now there's a lot of good statistical information. You could put all my numbers in here and say, hey, cancer's early, it's organ confined. And other ones are like, well, what treatment do I do? We finally are being more collegiate and putting the information with different treatments, whether it's radiation or radiation seeds or surgery. And what's my odds of being disease-free? Because again, education is so important. If you have a problem, it's what the heck can I do about it? Well, this is probably one of the most exciting, now that the dust is settling on early detection of prostate cancer, which it really is. The biggest question is, which cancer is good, which cancer is bad? And this has come up in the last 5 years, and this has certainly made my discussions with men with prostate cancer much more enjoyable and much more specific. Because before they would have a number X prostate cancer, and we didn't know if that number X was a good cancer or a bad cancer. So now that we know that the body is this dynamo of chemical reactions and protective cells and bad cells that make a bad environment where cancer cells can grow. But how do you tell the difference? So by getting techniques on it and learning about it, we now, if I have a cancer, I can put it through certain series of tests. There's about 3 of them out now that will tell me, hey, this is a favorable biology. My risk of this thing spreading is low. But hey, I have the same pathology, but man, this something funny about this one. And this is just one example, not to torture you, but this is an example of a test. They look at 4 properties of a particular cancer cell. And what they find is that stress, we all know stress is a problem, but stress with cancer cells. So here, the body does not handle, the cells don't handle stress well. Migration means cells getting away. They don't have the turnoffs that the cells can get away. Yet at the same time, for some reason, the body and these cells are able to divide and grow and reproduce. They have special properties. And even in their cellular makeup, their cellular matrix, they have the ability to grow when normally they couldn't. So by looking at these, it then divides the cells into, again, the good and bad. So when you're sitting in the office and Scott's terrified in front of you, you know, he has the biopsy, and all of a sudden everything lights up green. It's like, hey, you could watch this. You don't have to do something. You could watch it safely. PSA is a blood test that is helpful but not perfect to find prostate cancer, but as what's called a tumor marker, it is exceptional. There's very few cancers that you have a blood test that says, hey, what that blood test is what it's doing. So if my PSA isn't changing much, my checkup's not changing much, I just happily go along and follow life. If it changes, either I might decide on a treatment or I might have another biopsy, and then, hey, I'm reassured it's still okay, and I can wait. But if the things change and it's like, you know, these cells are getting too smart for my body, you may want to go to treatment. So this has been the other huge difference. So number one, we're biopsying a lot less men to find the same number of significant cancers. And number two is if I have a cancer and it is that 2/3 group, it helps me say, hey, is it safe to watch? Do I need to move on it? And these are just within such a short period of time. I would expect in 5-10 years to see a huge improvement even on that. It's got to happen. So a couple things to add to Dr. O'Brien, and she hit it with the last piece I came in for survivorship. When you ask about men in survivorship, it's interesting when you're trying to address what they need, they think different things. And the thing that always fascinated me is the financial health. And she highlighted that. And when you talk to a guy about cancer, and you get down and really calm them down, it's financial health is one of the biggest issues they're worried about. Then it's getting their emotional act together so they could be there for their family and loved ones. And then they're like, how do I care for my caregivers, who are helping them? It's amazing. And then sexuality is way down the list. So again, survivorship, like Dr. O'Brien was highlighting, is a little different for us guys, and we have to address that. This is a great thing on prostate cancer support groups. Fern McCure helped with the support group up in St. Albans for many years, and she always was like, why do guys get together? And this is universal, and this is survivorship as well, is to educate themselves. With web and thing, personal experiences from other men is invaluable, so they learn from each other. The other thing is positive thoughts. When you're in a group, you gotta stick together, and there's value to that. This kind of support group offers support to partners and spouses and families. And the fifth thing was always, how do we be proponents of early detection so no one else has, my kid and my family and my friend doesn't have to go through this. So it's really interesting, the support groups for men, so important. And it would be great to see those mature. Survivorship Network, just a couple of things to add to Dr. O'Brien. We are lucky in Vermont. We have Vermonters taking action against cancer. We have the Vermont Health Department and the Survivorship Network. And I'm not super computer literate, but online you can have incredible access to these resources for any type of man with cancer that really helps get you through it. And the Vermonters taking action against cancer, of course, we have Vermont Health Department won a huge grant from CD Center of Disease Control for the Vermont Cancer Plan, which has for physicians for education and for patients for education. And it's a huge, it's as good as anything there is, in North America, Canada, and US, and it's our own state's product. So I encourage you to check that, and VTAC. So that is a whirlwind on prostate. And now we're going to go into the other success story. See, you gave me so much stuff to do. So, and then I'll tackle whatever. So testicle cancer, again, is not the most common. About 9,000 young men in the United States will deal with it, though, so it is there. 1 in 500 men will deal with it. So if you start looking at it that way, you go, well, it's not that uncommon, I don't have to think about it. And if you think about the survivors, there's over 200,000 men who have survived testicular cancer. So it's a real issue, and certainly in that age group, that very tender age group of 15 to 40. So the testicle is in the scrotum. It's a paired organ. It must be important. And it originally starts in the belly and comes down just before birth. And the testicle has 95% of the testicle is sperm. So what you feel in there is actually sperm production at any age, and the rest is cells that support hormones. So the testicle has cells that make testosterone. 95% of the testosterone comes from here, and all the sperm come from here. And testicular cancer, the majority are sperm cells before they become sperm that go crazy. So they're testicular cells that decide to make growth in that age group. So what's important about, prevention? Prevention, again, there's no way to totally prevent it, but there's two things we could do. One is to know your risk. So there is hereditary testicular cancer. It's only about 5%. But if my brother had testis cancer, I got to watch closer. The second thing is an undescended testicle. Testicles come down from the body before we're born, or right around when we're born, but a fair number of them don't make it down, and they have to be brought down surgically or they don't come down. If a testicle does not come down on its own, you have a super higher risk of making a testis cancer. So one of the preventive strategies is if a young child has a testicle brought down, they always have to watch it. And the good thing about it is the way to find a testicular cancer is a painless lump in the testicle. It's very apparent to find. If a man finds a testicular lump, he sees his family doc, he says, yes, it's a lump. Then there's a simple ultrasound. Harmless sound waves will tell you yes or no, that's a bad lump. And testis cancer has these really cool blood tests which help us in treatment of those. So this is a ultrasound. Ultrasounds are sound waves. And the reason ultrasounds are black and white is because there's way more shades of gray than color. So this is a normal testicle, nice, boring, one big color of gray. It's not hard to see this big yucky mass here, and it's that straightforward. Now, testis cancer is curable at most stages with chemotherapy and radiation, but if you find it early, simply a surgery to remove a testicle, leaving the other normal testicle, will save you from having those treatments. So if you found a testicle cancer early, it saves you all those treatments. So that's the benefit. And an example, a mass this big, involving some of the testicle in as little as 6 months could involve the whole testicle, and the chance of it spreading goes way, way up. So again, I'm not on an anti-Congress U.S. Preventive Task Force, but the U.S. Preventive Task Force does not recommend any screening for testis cancer. And just to know how bureaucrats work, their advice is, well, if we have kids showing up with things that aren't testicle masses, things might be done to them that's going to make them stressed, and maybe procedures done to them, and we're going to cure them anyway. Well, there's two problems with that argument. One is, if you find it early, you're done. You don't have to have other treatment. The other thing, it's giving very little faith to the care system that they're going to use good common sense, and ultrasound might cost $200, but it's not going to hurt someone. So I see where they're coming from, but for testis cancer, I would get on my little pulpit that early detection, and the rest of the world, as you'll see, agrees, is hugely valuable to those men. Testis cancer, this is a computed tomography, which is a CAT scan of a body, and what's cool about this view is it looks like a body, right? There's a liver, 2 kidneys, really cool. This is important because testis cancer, testis started up here. If I have a testis cancer, we're going to look at this part of the body because testis cancer loves to spread by lymph nodes. So this is an example of the aorta and the vena cava, and believe it or not, the testis started here before the baby was born, then went down there, but it kept its roadwork of lymph nodes. So you see how this nice and boring, no lumps and bumps in here? Well, one of those people had this CAT scan, these big lumps and bumps, and that's when cancer is spread. So cancer of the testis could be just a silent lump and still have a significant problem. But these are the situations, even though the cancer is spread so far from home, very high cure rates with different chemotherapy and radiation. Again, why is it good to find early? And this is the bottom line. This is our own, SEER is every state puts in their cancer results. American Cancer Society reports it. So localized cancer, if I find a lump in the testicle and they don't have those lumps in the body, 99% cured, done. Regional, if they go to those lymph nodes, and this is the rationale, you don't have to find it early. You can give chemotherapy or radiation, and you can cure them almost the same. But those young men had radiation or chemotherapy, and we now know there are potential long-term side effects, especially if you're treating a 20-year-old who we expect to be around for at least 80 plus years. Distant disease, this is the success story. This is the Lance Armstrong who had brain, lung, every possible part of his body, had testis cancer, and 3 out of 4 get cured. But again, if you let prostate cancer get past the testicle, some men don't do as well. So the rest of the world definitely has huge check your testicles. And my son just finished school in England, and they have huge education, even at the college level, where they come in and say, check them. So testis self-exam is incredibly simple. A testicle is a hard-boiled egg without the shell. If there's a rock in it, you ain't gonna miss it. Used to do a lot of high school lectures and things. There was a lot of giggling, but years later you heard a lot of success stories of finding problems early. And again, it's a simple exam. You can't miss it. if they know to look. And most people in the United States, even with some of the ambiguity of us not having as big a PR program as other countries, because we've really rolled back because of the U.S. Preventive Task Force. But if you're in England or Australia, you will see these everywhere. Your life is in your hands. Check them. So it's an interesting world. So that's a whirlwind, but I did my charge, and I hope it was some interesting information. I'm happy to answer a few questions. Yes, sir.
If the prostate automatically gets larger as you grow older, what's the physician looking for if they're only using the rectal exam?
Lumps and bumps. So 15%, if I just did rectal exams, feeling the prostate in all men at all ages, 15%, you'd still feel a lump, even without using a PSA. That's what they're looking for. Yeah. Plus, the other thing, as Dr. Ganguly said, is 80% of rectal cancers are within the finger's width, or they get that blood test there.
So an annual physical pays off.
We, in the healthcare field, believe it does. Now, here's one of the kickers. I mentor the family practice residents right before they go into practice. And the reason they seek us out in urology is because of the ambiguity. So if you read, my wife's a family doc, just took her recertification. If you look, they'll say, we do not recommend digital rectal exam and PSAs at this time because of the U.S. Task Force and preventive. And I understand that, but they don't then substitute that with what you should do. So it's really left up to the medical community to decide. What they do say, which is great, they say talk to your doctor about the risk benefits and decide with your doctor what you want to do. So I think done correctly in the right hands, not jumping to conclusions, doing a physical exam and perhaps a PSA test in healthy men, at least between 50 and 70, and then if symptoms otherwise, is a prudent thing to consider. Yes, sir.
Can prostate cancer spread to the bladder?
Yes, meaning a local extension. Prostate cancer, like any cancer, can spread to the rectum and bladder because it lives next to it, or it can spread through the blood to bone in any place it wants to. Yeah, but most commonly bone, which, as you see, is a parallel to ladies and breast cancer. Yeah. Yes, sir.
Could you clarify, I didn't quite get whether the PSA will give you the difference between the bad and the good cancer, or does it have to go to the pathologist?
Yeah, that's a great question. The simple answer is yes. The trouble with PSA is PSA, in statistics term, is not super sensitive. So it's made by good and bad. So the game is absolutes, meaning if my PSA is inordinately high, that would point more to cancer. Watching it from year to year and see a rapid change would point more to cancer. But that's where those other blood tests also clarify. So those other blood tests, so if my blood test is elevated, I'm like, man, I don't feel anything. Is it good, is it bad? And I do those other blood tests, 60% of them will say, this is good PSA. But it's still not perfect. So still, by the time we recommend a biopsy, 40% of our people will not have cancer, even doing everything we could do. So you could take that as it's a bad test or it's a test that's not perfect. Fortunately, biopsies, you can get men through it, I think, in pretty good shape. 2 to 3% of men may get a very serious infection that need intravenous antibiotics. But other than that, it should be not a terrible thing. Yeah, but we try not to just because of the stress and the going through it if you don't have to. Yeah. Does that answer your question?
Yeah, so that's one reason why biopsies have been reduced so much.
Exactly,
That you have
exactly.
a blood test, which will give you a pretty good idea.
Exactly. So that's come way down. But yeah, the bottom line is the pathologist, because the pathologist is going to tell us, I simplify everything for myself. It's either going to say no cancer, which case they go into a super low risk, you reset the PSA, and that's, you go forward. Second thing though, which could be important, it could be precancerous. So if I have a 48-year-old guy who has a family history or a BRCA gene thing, and it comes back, this is precancerous but not cancer, he's going to go into a closer checkup, and then certainly cancer. And of course, if it's cancer, it's either 2/3 not so bad, 1/3, I want to know it because I want to make sure that person knows what he can do. Yes, sir.
When you have a BRCA in the family, when do you suggest starting the screening?
Yeah, age 40. Now, the good thing is Europeans have really helped us on that. So the Europeans say at age 40 you get a blood test, but they're smart. If the PSA is super low, then they don't need it again until they're 50. So they've done a lot more research than we have. So they're looking at how to lessen the risk. So putting all the information in the world together sometimes is the best way to go because people look at things differently. Yes, sir.
Biopsies can produce impotence, so isn't that a good reason to avoid biopsies?
That is a rare entity and not, it's less than 1% and it may be due to other things. So it's not thought to be a direct relation with a prostate biopsy. Yeah. The infections is the significant one. And like Dr. Ganguly says, there's some bugs that aren't so happy just in the community. So anytime you do not have to put a needle in something that might stir up an infection, you try not to. That's the biggest risk. Yeah. Great. Yes, sir.
So I'm 2 years out from my colon surgery, right, my colon removal. 5 years out from having my pancreas removed, and probably 14 years out from having pancreatic cancer. Are they going to put me through all this to keep track of my prostate, or are they going to say your survivorship isn't long enough to warrant such?
Yeah, well, again, if I've had any cancer, heart disease, and, my life expectancy is, I'm going to be around for a few years, we follow many men who maybe have other risk factors by just a blood test and just go on that because we can't feel it, might not be able to feel the prostate and just wait it out that way, yeah. But the big thing is, and you see all these governing boards and they're correct, is, you want to start with someone that's going to be worth their while for treatment. Now, the 1/3 of the cancers I mentioned that can affect our lives, these are things that can affect our lives within 5 years. This isn't something that, you're like, okay, Scott, you'll make it to 80 with your low-grade prostate cancer. That's a great way to be. But we're talking about trying to find, early detect the ones that could affect us. Yeah, yes, sir.
I was a little confused. If we have been diagnosed with prostate cancer, is the PSA test useful in tracking the degree of...
Yeah, that's like the best use. So the question is PSA good for if I have cancer? It's actually the best use. There's only a handful of cancers that you have that direct control over it.
What test you mentioned in addition to the PSA?
Mm-hmm. Yeah, those are not for cancer, but to see if I might have cancer. Yeah, and this is where way smarter minds than I'll ever be. It's actually a number of statisticians as well as basic scientists. So they found new proteins related to PSA. Then they do a number of calculations, then look at thousands of men, how they've done, and then they come back to us and say, this is what the blood test says, and this is significant. And that one blood test has been like close to 100% in my few dozen patients that I've been using it, that the ones that said you should think of a biopsy, they've all been worth their while. And it's also saved a lot of men from having biopsies.
So that blood test doesn't give you information about whether you're in the 2/3 group or the 1/3.
Correct. That's just getting in the door, should you even go through it. Then there's a whole nother test set of like genetic testing and gene testing to say, okay, which type am I? Yeah, so both groups are changing a lot. No, great questions. Thank you. And thank you all for your attention. I'd like to have Dr. Gary Stein, our director, say a few words, and thank you so much.
I'm applauding because this was an incredibly informative morning. Well, on behalf of my partner, Clara Verschragen, I want to express thanks to a number of people who have been absolutely instrumental in making this happen. Doctors Plant and Perrapato, I mean, your vision for what we should be able to go ahead and to share with the community has been very, very, very important. I learned a great deal from the morning here. Sarah Keblin and Charlie Brooks, I mean, you did a tremendous amount to be able to go ahead and to get this together and to keep Scott, Mark, and I on track. I'm saying that seriously. I mean, the focus was really important. And the staff at the Cancer Center, particularly our administrator, Kate Webster, Mano O'Connor, I mean, you've been very, very helpful with respect to making this event happen as well. People who I learned a great deal, and I could just tell from the questions that were raised during the sessions and during the breaks, Curtis Hem, Scott, Dr. Ganguly, and Dr. O'Brien, the information that you conveyed was incredibly important, and you presented it to us in a way that we understand it, and I am certain many of us will buy into it. But there was something that I sort of learned this morning, and that is, well, let me tell you the bad news, and I'll tell you the good news. I think the bad news is that maleness is probably not curable. And I mean, I heard that presented in the initial, Dr. Brunstad indicated that, and I think that was sort of reinforced by what a number of other people pointed out. However, the good news is that what is clear, maleness may be treatable. And that's something I think that we could go ahead and have some confidence in. I think the key message that came through was that early detection is more important than ever before. And when you look at the advances that are being made in cancer research and in clinical care, all that does is underscores the importance of being aware. And partnerships are very critical. Clinically, we're looking at partnerships. I mean, you've heard the relationship between the urologist, the surgeon, between the pathologist. That's very key. In the laboratory, again, it's the same thing. The Vermont Cancer Center, I think, is really a paradigm for that, where everything that happens is a partnership between a scientist and a physician investigator. But perhaps the most important partnerships are your partners at home, your families, and your friends. Make certain that you are not missing an opportunity to address any early warning sign of cancer. And speaking as a male, it's so evident that women understand that an annual checkup is very key. And most times when a sign and symptom presents itself, it's looked into and it's acted on. But speaking from my own experience and speaking from the experience of some of my male colleagues, that is often not the case. Physicians are probably the worst offenders of that. So please make certain that you take care of yourself. Your partners should make certain that you do if in fact you aren't. And this should not be an option. It should be an obligation to yourself and to the people who are important to you. So again, I want to thank everybody for attending, the folks who have gone ahead and presented lessons to us. That's been incredibly important. But the questions that have been raised by the group have been equally important. The University of Vermont Cancer Center is here to be able to address any questions that you have. We want to hear from you. And I think you should be proud of the fact that in Vermont you have the most incredible opportunity for healthcare. Lastly, I want to thank the Vermont Department of Health, VTAC, the clinical system, and the Cancer Center, and most important, you folks. So thank you for spending the morning with us.